Okay, hello everyone. We'll continue with adrenergic antagonists. Okay, these are the drugs that block the effect of sympathetic stimulation and adrenergic agonists. It is through they block the effect of sympathetic stimulation and also they block the effect of adrenergic agonist that is mediated through alpha and beta receptors. Okay, so if they block the effect of sympathetic stimulation and they block the effect of adrenergic agonist, these both actions are mediated through alpha and beta receptors. Okay, first of all we'll discuss about the alpha blockers, then we'll discuss about the beta blockers. Okay, so the alpha blockers. The most important thing that you need to remember about the alpha blockers is that they decrease the total peripheral resistance. Okay, this is the most important thing that you need to remember about the alpha blocker is that they decrease the total peripheral resistance and decrease the mean blood pressure. Okay, so what are the types of alpha blockers? Okay, there are three types of alpha blockers. The first one is non-selective, that is these drugs they block both alpha 1 and alpha 2 receptors. Okay, the second one is alpha 1 selective, those drugs that only selectively block the alpha 1 receptors. And similarly, number 3, alpha 2 selective antagonist. Okay, so the non-selective alpha blockers are phentolamine and phenoxybenzamine. Okay, we'll discuss about these drugs in a bit brief after we classify these drugs and after we have dealt with the effects of these drugs. Okay, so phentolamine, it is a competitive inhibitor, and phenoxybenzamine, it is a non-competitive inhibitor. Okay, so the selective alpha 1 blockers are, okay, remember this, josin and leucin. Okay, josin, josin and leucin. Prazosin, doxazosin, terazosin and tamsulosin. Okay, these are selective alpha 1 blockers. And the last one is selective alpha 2 blockers. Okay, we have only one drug here, mitrazepine. Okay, and we used to have another drug known called yohimbine, but it is not used currently. Okay, so these are the alpha blockers. Next we'll see what are the effects of these alpha blocking agents on various organs. Okay, so the effects of alpha blockers. Okay, so on the eye, they act on the alpha 1 receptor of the eye, these drugs. Okay, as a whole we are discussing the effect of as a whole alpha blockers. Okay, they act on the alpha 1 receptor in the eye, mainly in the dilator pupillae muscle, and block its action. So if the pupil is not getting dilated, means it is getting constricted, causing miosis. Okay, next one is the GI system. Okay, these drugs they increase the motility of the gastrointestinal tract, and also they cause relaxation of the sphincters, causing diarrhea. Okay, on the blood vessels, if they act on arterial, okay, if the action is on arterial, then they cause arterial dilation. Okay, and arterial dilation will decrease the total peripheral resistance, thus decreasing the afterload and thus decreasing the blood pressure. Okay, on the venule side, it causes decrease in the preload. Okay, the next one is bladder. On the bladder, these drugs cause relaxation of smooth muscles in trigone, sphincter and the prostate. Okay, so these drugs are used in people with benign prostatic hyperplasia to decrease the resistance of flow to the urine. Okay, to make it easy for the person to urinate. Okay, the next one is the effect on vas deferens. Okay, these drugs they cause impaired ejaculation and impotence. Okay, if someone is on alpha blockers, they may complain of that they are not able to ejaculate and it is causing impotence. Okay, Lastly, the action of these alpha blockers on presynaptic alpha 2 receptors. Okay, the presynaptic alpha 2 receptor, they control the negative feedback loop. Okay, if these presynaptic alpha 2 receptor are stimulated, okay, if these are stimulated, then the release of norepinephrine is decreased. But remember, alpha blockers will block this receptor, thus decreasing the negative feedback and increasing the release of norepinephrine, which may cause increase in heart rate or tachycardia and palpitations. Okay, so these are the effect of alpha blockers. Okay, you can easily remember those if you remember the effect of what happens if alpha receptors are stimulated, or effect of sympathetic stimulation on the various organs. Okay, okay. Next we'll discuss about, and if you want to know what are the effects of sympathetic stimulation on various organs, please see the previous videos. Okay, next we'll discuss something about these individual drugs and the uses. Okay, then after that we'll discuss about beta blockers. Okay, now we'll discuss some important points regarding these individual drugs. Okay, so first of all, phenoxybenzamine. Remember that this it is a non-selective alpha blocker. Okay, it irreversibly blocks the alpha receptor, that is, it has long duration of action. Okay, and it also inhibits the norepinephrine uptake. Okay, remember these points. Remember that in higher doses it also blocks histamine, cholinergic and serotonin receptors. Okay, so the use, where do we use this phenoxybenzamine? We use it in the treatment of pheochromocytoma. Okay, what is pheochromocytoma? It is a tumor of the adrenal gland. Okay, mainly of the adrenal medulla. This tumor secretes large amount of catecholamines, mainly epinephrine. Okay, the patient classically presents with palpitation, increased sweating. The patient is usually anxious, and they also present with headache. Okay, means sympathetic overstimulation. They present with features of sympathetic overstimulation. Okay, we'll discuss a bit later why these drugs are used in pheochromocytoma. Okay, so what are the side effects of phenoxybenzamine? Being an alpha blocker, it causes postural hypertension. Okay, what happens is that if you are sitting or lying down for some while, and then you suddenly wake up from your sitting or lying down position, then your blood pressure drops. Okay, systolic more than 20 mmHg, then it is called postural hypertension. Okay, even after 3 to 3 minutes of standing, if your blood pressure is low, okay, it is called postural hypertension, and you may suddenly feel dizzy or may even fall down. It is more common in elderly, and they may even fall down, causing trauma to the various organs. Okay, normally what happens is that since we are blocking these alpha blockers, there is no any alpha mediated vasoconstriction. So once you get up from a sitting or lying down position, the vasoconstriction does not occur, so cardiac output falls. Okay, the blood is pulled in the legs. Okay, pulled in the lower limbs. Okay, it does not, the venous return decreases since there is no venoconstriction, and causing a sudden change in blood pressure, that is hypotension, and patient may even fall. So another one is reflex tachycardia. Okay, it is a reflex response, as a sympathetic response to this postural hypotension. Similarly, palpitations. We already discussed about how it causes diarrhea. Okay, remember the alpha 1 agonist are used in the treatment of nasal decongestants. So these alpha blockers, they can increase the edema there and cause nasal stuffiness and impotence. Okay, next we'll discuss about something about phentolamine. So next is phentolamine. Okay, phentolamine, it is also a non-selective alpha blocker. Okay, remember that it has more venodilation as compared to arteriodilation, it causes more venodilation. Okay, it also blocks 5-HT or sorry, sorry about that. It also blocks serotonin receptors, calcium channels, and can cause histamine release from mast cell. Okay, it has shorter duration action. Okay, remember that phenoxybenzamine was an irreversible blocker, so it used to cause longer duration of action, whereas phentolamine, it causes reversible blockade, thus it has shorter duration of action. So the side effects are kind of similar: tachycardia, palpitation, arrhythmia, angina, and these can even precipitate myocardial infarction. Okay, so how these can precipitate angina and arrhythmia? Remember, these are increasing the heart rate. Okay, if the heart rate increases, the cardiac work increases, and if the cardiac work increases, then the cardiac oxygen demand increases. Okay, so there is increase in oxygen demand, but it is also causing arteriodilation and venodilation. Thus, enough preload uh, may not, okay, enough preload and afterload may not be there to supply the coronary circulation, thus precipitating MI and angina. Okay, next we'll discuss about this something about the selective alpha 1 blockers. Okay, the selective alpha 1 blockers are prazosin, terazosin, doxazosin, tamsulosin. Okay, so zosin and losins. Okay, prazosin. Okay, it is a selective alpha 1 blocker. So the prazosin, it causes minimal or no tachycardia. Okay, these selective alpha 1 blockers, they cause minimal or no tachycardia, and these have more arterial dilating capacity than venodilation. Okay, so the side effects are: first dose hypotension. Okay, suppose you give prazosin to someone, and within 30 to 90 minutes they can have postural hypotension. Okay, this is first dose postural hypotension. So what you do is that if you have to prescribe prazosin to some person, to a patient, then you use generally start with low dose and gradually you increase the dose, and it is better if you give this drug at bedtime. Okay, so okay, let me write it: bed time. So the persons are lying down in bed, which decreases the chance of syncopal attacks due to postural hypotension. Okay. Remember, another drug, okay, ACE inhibitors, they also have this first dose phenomenon. Okay, next is doxazosin. It is the longest acting alpha 1 blocker. Okay, now the losin, okay, tamsulosin. It is used in benign prostatic hyperplasia. Okay, it is an alpha 1 antagonist, mainly alpha 1A antagonist. It dilates the prostatic part of the urethra and making it easier for the persons, mainly elderly male, to urinate. Okay, and the major side effect is it can cause retrograde ejaculation. Okay, now we'll discuss about what are some therapeutic uses. Okay, let me change into therapeutic uses. What are the therapeutic uses? These drugs, mainly phenoxybenzamine and phentolamine, they are used in, okay, let me change the color. They are used in treatment of pheochromocytoma. Why these drugs are used in treatment of pheochromocytoma is because phenoxybenzamine, it controls the blood pressure and also restores the blood volume. Okay, so another drug is propanolol. Propanolol is used to control the cardiac manifestations, that is increased heart rate, palpitations. Okay, remember, always have alpha blockage before giving a beta blocker in pheochromocytoma. Means always give this phenoxybenzamine, which is an alpha blocker, before giving propanolol, which is an beta blocker. Why? If you give propanolol ahead of phenoxybenzamine, or if you only give beta blocker, then what happens is that your beta receptors are blocked, but your alpha receptors are acting. Okay, So the sympathetic system will act on the alpha receptors, causing widespread vasoconstriction and hypertensive crisis. The large amount of catecholamines released from this pheochromocytoma tumor will cause hypertensive crisis if there is no any adequate alpha blockade before giving beta blockers. Okay, so if the patient is undergoing surgery for the treatment of pheochromocytoma and during handling of the tumor, release of large quantity of catecholamines from the tumor may occur, which can cause sudden severe increase in the blood pressure. So what do? You give IV phentolamine. Okay, IV phentolamine. So this is the reason why phenoxybenzamine and phentolamine are used in the treatment of pheochromocytoma. Okay, next is these alpha blockers are used in hypertensive emergencies. Okay, for example, intraoperative during pheochromocytoma removal. Another is during cheese reaction. Another is during clonidine withdrawal. Remember, clonidine is a centrally acting antihypertensive drug, and if there is a sudden withdrawal, then it can cause massive vasoconstriction, causing hypertensive emergencies. Okay, the next one is if the patient has BPH and also has hypertension, then you can give drugs like prazosin, doxazosin. And the patient has only benign prostatic hyperplasia and no hypertension, then you can give tamsulosin. Okay, next we'll discuss about the beta blockers. Okay, remember these alpha blockers and beta blockers. These are very high yield topics. Okay, so see you next time. Okay, next we continue with the beta blockers. Okay, these are the drugs that block the actions of beta agonist and also block the action of sympathetic system that is mediated via the beta receptors. Okay, let me change the color here. Okay, so what are the, remember this is a very high yield topic on the USMLE exams, and even in clinical practices these beta blockers are used day in and day out. Okay, so what are the types of beta blockers? Okay, first one is the non-selective beta blockers, second one is beta selective, and the third one is beta blockers with additional vasodilatory effect. So the non-selective beta blockers are propanolol, timolol, sotalol, and pindolol. Okay, these most of these beta blockers, they have LOL in the last of their name. Okay, so propanolol, timolol, sotalol, pindolol, and levobuinolol. Okay, this sotalol has a special feature that it can block potassium channel as well as beta blockers. Okay, the next are beta 1 selective, or remember the beta 1 receptors are mainly in the heart and juxtaglomerular receptors. So cardio selective beta blockers. Okay, atenolol, metoprolol, esmolol, and bisoprolol. Okay, so these four: atenolol, metoprolol, esmolol, bisoprolol, and another one is acebutolol. Okay, these are safer in asthmatics, in patients with COPD, and the patients that have peripheral arterial disease. Okay, since these are cardio selective. The remember that the bronchioles have beta 1 receptor. Okay, and if you block those bronchodilatory beta 1 receptors, then it may precipitate bronchoconstriction, causing asthma, and similar in peripheral arterial disease. Okay, since they are cardioselective, they are safer in these patients. So the third one is beta blockers that have additional vasodilatory effect. Okay, this vasodilatory effect is due to additional alpha 1 blockade. Okay, so additional alpha 1 blockage. Okay, so the non-selective types are labetalol and carvedilol, and beta 1 selective are betoxolol, celiprolol, and nebivolol. Okay, so these are the classification of beta blockers: non-selective, cardioselective, and those with additional vasodilatory effect. Okay, Okay, there among these uh, beta blockers, okay, pindolol, acebutolol, labetalol, celiprolol, okay, these have partial agonistic activity. Okay, these have. So let me write those drugs down first. Okay, pindolol, acebutolol, labetalol. Forgive my handwriting, please. Celiprolol, and another one is cartiolol. These have partial agonistic activity. Even though these are antagonists, beta antagonists, these are partial agonistic activity. That is, remember this term, ISA, intrinsic sympathomimetic activity. Okay, these can stimulate beta receptor, particularly in the absence of catecholamines. Okay, due to their antagonistic feature, if the catecholamines are absent, then they can stimulate these beta receptors. Okay, so these drugs with intrinsic sympathomimetic activity, they produce less bradycardia. Okay, they have slightly vaso and bronchodilatory effect. They produce minimal change in plasma lipids. Okay, so less bradycardia due to beta 1 receptor, broncho and vasodilation due to beta 2 receptor, and minimal change in plasma lipid through beta 2 receptor. We'll see these okay in we'll see the actions of beta blockers next. Okay, what effect they produced in different organs. Okay, now we'll discuss about the actions of these beta blockers on various organs. Okay, starting with the heart. The heart has beta 1 type of receptor. Okay, so what these beta blockers do is that they act on the various parts of heart. Okay, if they act on the SA node, they will decrease the heart rate, that is negative chronotropic action. They also act on the myocardium and decrease the force of contraction, that is negative chronotropic effect, sorry, negative ionotropic effect. And they also decrease the cardiac output. Okay, they act on the AV node and they decrease the AV nodal activity, and they increase the AV nodal refractory period. Okay, thus they have negative dromotrophic effect, that is they decrease the conduction velocity also. Okay, one important point is that these drugs, beta blockers, they decrease the automaticity of ectopic foci. Okay, that means they decrease the firing from an ectopic foci, decreasing the risk of arrhythmias. Okay, so these beta blockers, mainly metoprolol, these are used in arrhythmias, mainly atrial arrhythmias. Okay, like atrial fibrillation, atrial flutter. So since they decrease the heart rate, force of contraction, and cardiac output, they decrease the cardiac workload and thus decrease the cardiac oxygen requirement. Okay, remember that at higher doses, metoprolol and carbidopa, they act as membrane stabilizers. Okay, but only in high dose. So these are the cardiac actions. Next, we'll discuss about the action on. Okay, let me switch it. Blood vessels. Okay, very good. Blood vessels, they have beta 1 type of receptor. Okay, basically what they do is they decrease in systolic blood pressure and diastolic blood pressure both. Okay, but remember, initially due to beta blockage, there occurs on opposite alpha 1 action, increasing the total peripheral resistance. But continued administration of beta blockers, okay, leads to a fall in total peripheral resistance, mainly in patient with hypertension, due to chronic reduction in cardiac output. These beta blockers in the long term cause chronic reduction in cardiac output, thus causing decrease in both systolic and diastolic blood pressure. Okay, and if they act on the kidney, they cause decrease in renin release. Okay, remember, renin. It is finally responsible for for the production of angiotensin 2. Okay, so what does this angiotensin do is it increases the sympathetic activity, number one. It increases the aldosterone secretion from the adrenal cortex, thus promoting sodium and water retention. It also promotes tubular sodium chloride resorption and potassium excretion. Okay, it promotes arterial vasoconstriction also, and finally it causes ADH secretion from pituitary, thus causing water resorption. So if there is decreased renin release due to beta blockers, all these angiotensin 2 mediated responses are are nullified. Okay, means decrease in sympathetic activity, decrease in sodium and water retention, there occurs vasodilation, okay, so, and decrease in ADS release from the pituitary. Next is their effect on lungs. Okay, lungs have beta 2 type of receptors, so it may cause bronchospasm, thus they are avoided in asthmatics and COPD. Okay, now the fourth one is their action on muscles. Okay, muscles due to beta blockers, patient may complain of muscle weakness and tiredness. This occurs because beta 2 receptors usually dilate the blood vessels supplying the muscles, and beta blockers oppose this action. Thus, less blood reaches the muscle and the muscle gets easily tired and fatigued. The next is reduced stress induced tremors. Okay, if you are in a stressful condition, anxiety, suppose you have exams tomorrow or today in a few hours, then you may get stress induced tremors, and these beta blockers like propranolol, they are very helpful in these conditions. Okay, the next is metabolic effects of beta blockers. Okay, so the metabolic effects of beta blockers are they decrease glycogenolysis and decrease gluconeogenesis. Okay, means the glycogen is not being converted into glucose, and new glucose from sources like protein is not being formed. Okay, next is these drug beta 2 blockers, they are beta blockers, okay, mainly due to beta 2 action, cause delay recovery from hypoglycemia. Okay, and they also mask the warning signs of hypoglycemia. Okay, the warning signs of hypoglycemia are mainly due to sympathetic stimulation. Okay, palpitation, tremor, sweating, and if you give beta blocker, you are blocking these sympathetic symptoms. Okay, so they may mask the warning signs and symptoms of hypoglycemia. So be very careful if you are giving these beta blockers in patients that have diabetic. Okay, the third one is they tamper with the lipids. Okay, see, I have written this TAMP in capital. This is a mnemonic: T for timolol, A for atenolol, M for metoprolol, and P is for propranolol. These four drugs, they increase the LDL and triglyceride levels, so they tamper with the lipids. On acting on the eye, they cause decrease in aqueous production and decrease intraocular pressure. Okay, remember that propranolol is very highly lipid soluble, and thus it can enter the central nervous system. Next, we'll discuss about the side effects. Okay, remember the side effects are basically if there occurs more of this action. Okay, more action of these drugs will produce side effects. Okay, then we'll discuss something about the drug interactions of beta blocker, and finally uses. Okay, now we'll discuss about the side effects of these beta blockers. Okay, these are the extension of their action on various organ. So on cardiovascular organ, they may cause decrease in heart rate, and even they may cause heart blocks. Okay, if some patients they have low cardiac reserve, then if you give beta blockers to this patient, then they may land up into you may precipitate congestive cardiac failure in this patient. So decrease heart rate, heart blocks, and CCF. Okay, you may also worsen the peripheral arterial disease since you are blocking the vasodilatory effect. they occurs only vasoconstrictive effect of alpha receptors. Okay, so you are exacerbating or worsening the peripheral arterial disease. Okay, peripheral arterial disease, and you may also exacerbate prinzmental angina, that is vasospastic angina. Next is the respiratory system, bronchoconstriction. Okay, so these are contraindicated in asthmatics and person with COPD. On central nervous system, they can cause sleep disturbances, hallucinations, fatigue, and depression. Okay, the metabolic changes we have already discussed. They delay the recovery from hypoglycemia. They alter the lipid profile. Okay, they cause muscular weakness and tiredness. Okay, remember that beta blockers withdrawal in chronic users. Okay, if you are okay, let me write it. Withdrawal. Okay, and chronic is just if someone is using beta blockers from long period of time and they suddenly forget taking or stop taking the drug, it can cause angina. It can even cause frank MI or sudden cardiac death. Okay, what happens is that if you're blocking the beta receptor for such a long period of time, okay, the body makes new beta receptors. Okay, they accumulate a lot of beta receptors. Okay, and this is called upregulations of beta receptor. Okay, this is called upregulations. The body makes a lot of beta receptors. Okay, and if suddenly this beta receptor induced blockade is removed, what happens? Overactivity of beta receptors occur. Sympathetic beta receptor occurs. Okay, causing angina, frank MI, or even sudden cardiac death. Okay, remember that the drug labetalol is hepatotoxic, but it is safe in pregnancy. Okay, labetalol is one of the drug to control hypertension in pregnancy. Okay, not side effect, but something regarding carvedilol. Okay, something regarding carvedilol. Carvedilol. Okay, it has antioxidant, anti-proliferative, membrane stabilizing, and vasodilatory property. So antioxidant, anti-proliferative. Okay, another one is membrane stabilizing activity, and the other one is in vasodilatory property. Okay, and thus it is cardioprotective on long-term use, and it decreases mortality in patient with congestive cardiac failure. Okay, next we'll discuss about the drug interactions of these beta blockers. Okay, first one is with verapamil versus propranolol. Okay, so verapamil, it is a calcium channel blocker, and if you give beta blocker, then these both drug will cause cardiac depression. Okay, their action will combine and cause additive cardiac depression, thus causing congestive cardiac failure, heart blocks, bradyarrhythmias, and even cardiac arrest. Okay, second one is lignocaine versus propranolol. Forgive my handwriting. Okay, propranolol will decrease the hepatic blood flow, thus reducing the clearance of lignocaine. Okay, means lignocaine will act for longer time. Okay, insulin or sulfonylureas versus beta blockers. Okay, since this beta blocker inhibit glycolysis and delay the recovery from hypoglycemia, okay, you may have problems if you give beta blockers in person taking insulin or sulfonylurea. So be very cautious. Okay, the last one is non-steroidal anti-inflammatory drugs versus propranolol. Okay, these NSAIDs, they inhibit prostaglandin synthesis and promote sodium and water retention on chronic use. And this may be opposite. Okay, this will decrease the antihypertensive properties of beta blockers. Okay, remember that like glucagon, it is used if there is beta blocker overdose. Okay, let me write it. Glucagon, it is used in beta blocker overdose. Okay, why it is used in beta blocker overdose? Okay, it has positive ionotropic and chronotropic effect. That is, it increases the heart rate and it also increases the force of contraction. Okay, increases heart rate, increases force of contraction. That is opposite action to that of beta blockers. Okay, these actions, they take place through glucagon receptors that are G protein receptors linked to adenylyl cyclase. Okay, not via beta receptors but through G protein couple receptors. Okay, so this is the basis of use of glucagon in beta blocker overdose. Okay, so next is the uses of these beta blockers. Okay, we have already discussed during classification. Okay, what are the uses? Let me remind you. One is hypertension. Okay, if the patient, they have hypertension and with angina, MI and arrhythmias, okay, you can use beta blockers. Okay, hypertension mainly in patient with MI, angina and arrhythmias. Okay, second is angina prophylaxis. In angina prophylaxis and prophylaxis after MI. Okay, angina prophylaxis. Okay, these decrease the heart rate, these decrease the force of contraction, thus decreasing the cardiac workload and decreasing the oxygen demand. Okay, in the acute phase of MI, they limit the infarct size. Okay, so acute phase of MI, limit infarct size, and in long term they decrease the mortality and risk of reinfarction. Okay, the third use is in the control of arrhythmias. Okay, we've already discussed that they decrease the automaticity of ectopic foci. So arrhythmias, mainly atrial. Okay, atrial arrhythmias, atrial fibrillation, flutter and paroxysmal supraventricular tachycardia. The next is congestive cardiac failure. Okay, the next is pheochromocytoma. Okay, these are given after adequate alpha blockade to control the cardiac manifestations. Okay, the next is in glaucoma. Okay, in glaucoma, because they decrease aqueous humor production. Okay, the next use, it is very commonly used in the prophylaxis of migraine. Okay, okay, migraine prophylaxis. Okay, propanolol, metoprolol. Okay, they decrease the frequency of headaches. Okay, the mechanism is unknown. Okay, remember the headaches are usually due to dilatation of blood vessels inside the brain. Okay, these beta blockers will cause alpha mediated vasoconstriction. Since these are blocking the beta receptors, alpha mediated vasoconstriction will occur, and that may be the reason behind decreasing headache, but the actual mechanism is unknown. Next is in patient of hyperthyroidism, to decrease or control the tachycardia, palpitations, tremor and anxiety, mainly to control the sympathetic overstimulation. Okay, next is in alcohol withdrawal, similar thing here. Next is in hypertrophic obstructive cardiomyopathy. Okay, propanolol decreases the outflow resistance in these patients. Okay, the last one is dissecting aortic aneurysm. What happens is that decrease in cardiac contractility and the rate of development of pressure during systole is caused by these beta blockers. Thus, they decrease the dissection of the aorta of the aortic aneurysm. Okay, so this was all about the beta blockers and alpha blockers. Now we have completed the autonomic pharmacology. Next, we'll discuss about the drug used in Parkinsonism. Okay, we enter into central nervous system. Okay, bye bye till next time.